Hi, and welcome to Neurocare Academy. My name is Dr. Trevor Brown, and today we have the pleasure of having Dr. Martijn Arns with us. Hi, Martijn. How are you going?
Pretty good. How about yourself?
Yeah,
Here.
Doing very well, thank you. Now, Martijn is the director of Brain Clinics Foundation in Nijmegen, Netherlands, associate professor at Maastricht University, and an advisor to Neurocare Group. And you're going to talk to us a little bit about localization of TMS pulses today. Would you like to summarize a little bit very quickly what you're going to be talking about for us, Martijn?
Yeah, I think some people might know we've been working on what we think is hopefully going to be a new way, a more innovative way of finding the thumb switch of the prefrontal cortex, because nowadays we need to guess pretty much where we're going to be stimulating. And as some of the listeners might know, I mean, we've been using heart rate for that. So I'll be sharing some of the data on the history, how we got to that idea and what we've published so far. And then I'll probably give some new insights as well.
Excellent. Well, just before you do that, perhaps I'll start off with a little bit of background about localization of rTMS around the dorsolateral prefrontal cortex and how that's developed over the years. Okay, so just as some background information before we hear from Martijn, rTMS for the treatment of depression began by using what's called the 5 centimeter rule in order to find the DLPFC, the stimulation site that's most implicated in the antidepressant effects of rTMS. So to do this, as seen on the left, MT was found over the motor strip and the DLPFC was marked as being 5 centimeters anterior to that MT location. So you can see on the left there, the MT was found and then 5 centimeters forward, this was adjudged to be the DLPFC. This led to quite good effectiveness as seen by the Carpenter and colleagues clinical trial in 2012. And lots of early studies used this 5 centimeter rule, still getting good clinical results. The 5 centimeter rule location falls as marked in this image from Fitzgerald 2021, along with another site labelled P2, in which positive clinical outcomes have also been found. We'll call these two dots the 5 centimeter cluster. But there have also been a number of studies based on locations more anterior, which we'll call the Beam F3 cluster, here shown by the dot labelled B3. The DLPFC location can be found using this Beam method, designed by William Beam, which accounts for head size, and as shown by Mir Mogtaday and colleagues in 2015, the Beam F3 method provides a very reasonable approximation of MRI-guided DLPFC localization. The difference being between the two is actually quite minimal. And as we saw from the Blumberger trial in 2018, in which both ITBs and 10 Hz stimulation patterns showed similar results, both patterns used MRI-guided technique for DLPFC localization, and response remission rates were quite similar to previous trials. So effectiveness doesn't seem to be improving when using one method over another to localize DLPFC at a group level. It was further shown this year by Hebel and colleagues that MRI-guided ITBs was not superior as a localization method. Differences were negligible and did not justify the added expense of neuronavigation. We see that along with Beam F3, in that cluster where there are other studies with positive outcomes labeled P1 and FX1, which have also had positive clinical outcomes. The latter, FX1, having even been guided by connectivity between the DLPFC and subgenual anterior cingulate cortex, which is considered a vital element in the antidepressant effects of rTMS. There's a pulse at the DLPFC, and the SGACC activation is anti-correlated to the pulse, signifying a send-receive mechanism between the two sites. But if connectivity between DLPFC and SGACC are so important, why do we also have a 5 centimeter cluster giving similar results? Well, to further look into this point, when looking at the connectivity between DLPFC and SGACC, Fox and colleagues showed that a group map will show the location being quite anterior, but also quite widespread, because it's an average of all individuals. And of course, there are individual differences as seen here between subject 1 and subject 2. For some, it's anterior and some more posterior, which might explain the two clusters seen in the previous slide. So if neuronavigation of the DLPFC does not increase results because this doesn't necessarily connect with SGACC for everyone, how can we find the connectivity between the DLPFC and SGACC? And is that connectivity always going to be related to rTMS results. To address this point, Fitzgerald 2021 in his article states, "It's also possible that some patients are just likely to be better off treated at a posterior site, and others more anteriorly due to the connectivity of the networks or individual elements of prefrontal anatomy." And he goes on to say that it may well be that treatment responses have remained modest regardless of treatment target, because with any one non-personalized target, posterior or anterior, only a subgroup of patients is receiving optimal stimulation. So to summarize, we need to try to find the optimal site for each individual, which may be in the 5 centimeter or BMF3 cluster. The optimal location might mostly be reliant on DLPFC, SGACC connectivity for that individual, but the relationship to depressive symptoms might not always be only the connectivity between DLPFC and SGACC. There might be different networks involved or individual anatomy to account for. But if we can at least localize for each individual which one of the two clusters has optimal clinical outcome, then we may be able to treat both main subgroups effectively. So the question is, how can we target an individual's depression network without an fMRI machine, which is cost and time prohibitive to a clinician? So I'm really excited to learn about what you propose we can do to address this problem, Martijn.
All right, thanks, Trevor, for this great introduction. Indeed, I think this is really what it's all about. I mean, on the group average level, and we know that one target is effective. We know that for another target on a group level, again, is effective as well. But I think the real truth of the matter, the real thing we want to know is which person is most responsive to which subcluster. And that's really something, because that would really allow for a stratified psychiatry approach, where we can simply assign someone to a given treatment target on an individual basis based on individual biomarkers, if you will. But now the question is, what should be that biomarker? And indeed, as you've shown already, I think this slide by Michael Fox and Pascal Leon, I think has been a real big inspiration. And it was really about, in very simplistic terms, finding the highway to the subgenuine anterior cingulate. And you want to find that prefrontal area in an individualized way that is most effective in transsynaptically activating the subgenuine anterior cingulate. And they've done quite a bit of work and shown that was quite promising and real promising way forward. Although no prospective trials, at least to my knowledge, maybe apart from the SANE trial, have been run using this method yet. So our main question was, well, how could we achieve a similar kind of thing, but then without using the MRI? And of course, one of the first things that we tried to focus on is the EEG, because we have a big background in EEG. We do a lot of EEG research, and we also have access to a very large data set called the iSpot trial. And knowing from the work from Diego Pizzagalli that you can actually look at the subgenual anterior cingulate, which is area 25, but he delineated a much more fine-grained kind of structure, and he refers to this blue region as the rostral anterior cingulate. And this rostral anterior cingulate has been very well known as a kind of hub that can tell you if someone will respond to an antidepressant treatment or not. It's irrespective to what specific treatment, but there's a lot of research on MRI, on PET scanning, and also EEG work using Loretta source reconstructed EEG, that you can extract the activity here and therefore predict someone's treatment response. Well, we then thought that's an interesting way, so let's use a similar kind of approach, use Loretta, but you can also use Loretta to calculate connectivity. And so we defined, based on Fox's earlier work, various regions, of course, the subgenuine anterior cingulate, also the right and left dorsolateral prefrontal cortex, based on the Fitzgerald targets. And then we also defined the medial prefrontal cortex, given there was some evidence from Jonathan Downey's group that the medial prefrontal cortex could be a good target as well. To cut a long story short, we looked at many things, but in the end, using 1,000+ sample size, which I think is really large, we could not find really strong predictors for a response to antidepressant medication. No baseline predictors emerged, but we did find small effect sizes and very strong sex-specific effects, meaning that the connectivity was completely different for males and females. So a long story short, we weren't feeling that this was really bringing us to a method that we could be utilizing on the individual level to then find the right connected area in the prefrontal cortex. So then, as very often, you will see that that's coincidence or has some kind of an aha erlebnis plays a big role in new findings. And we were still finding and looking into the literature, how can we really find this kind of connectivity in a different way. But it was only when we came across this study when I finally thought, like, this could be interesting. So this is a very old study out of 1964. This also taught me that you shouldn't judge a paper based on its title. The title of the paper was Localization for Penile Erection in the Medial Frontal Lobe. So these researchers were actually stimulating, using electrical stimulation in the monkey model, a lot of the prefrontal ACC regions, if you will. And as a kind of side note, they mentioned under the heading cardiac changes, as evident in figure 9, cardiac slowing of 10 to 60% of the initial heart rate was elicited by stimulation at widespread points in the medial frontal region. And so this for me was like, hey, this could be interesting. So if there's somehow transsynaptic activation of the subgenuine anterior cingulate, that should then also be able to be captured by measuring the heart rate. And that's how we started experimenting first on my own brain, which is always the first brain to go in our lab to test things out. And from the beginning onwards, we're quite surprised to see the immediate onset of heart rate deceleration when you were targeting a specific region. And sometimes even between the beam F3/4 site or the 5 centimeter site, it could make a difference of being accelerating or decelerating effects on the heart rate. So showing a high degree of specificity. So that's also how we indeed then, here we reviewed that in a whole extensive review published in Brain Stimulation, where we review the whole pathways involved in the neuroanatomy of what we call the frontal vagal pathway. And so in a sense, we are aiming our stimulation at the dorsolateral prefrontal cortex. We know that there's transsynaptic, at least functional connectivity. There's no structural connectivity with the subgenuine anterior cingulate. And we know that the whole network that's involved in parasympathetic regulation involves many nodes, and this method, and by impacting on this network, is I think then a perfect target engagement method to stimulate on areas here and read out the subsequent changes in heart rate to gauge if you're aiming at the right network or aiming in a different network. So this is how the first paper, we now call this NCG TMS 1.0. Pay a lot of attention to that because we think that the NCG TMS 2.0, which is fundamentally different, captures this even better. Maybe more about that later. But in essence, we measure the EKG in real time, and we co-register the TMS pulses in a second channel of the equipment. Then we reconstruct the EKG to RR intervals. So we measure the time between every R peak, which is then plotted in this time series here. Then also appreciate that the time scale is completely different because this is only reflecting the RR intervals between two R peaks. And this is also a completely different wave shape than what you see here. So here we see, for example, the stimulation time at FC4, which is one specific location, is just 5 seconds. Here we see C4 and here we see F4. And you can already see, like in this case at F4, there's a real nice heart rate deceleration taking place. And the length between two RR intervals is increasing, and therefore we see an upward arrow in this area. One thing that was a little bit tricky is that you can also see this kind of a rhythm that is running through all these RR intervals, which is very well known to be respiratory sinus arrhythmia. So every time you inhale and exhale, you will see your heart rate accelerating and decelerating, and that's this kind of a sine wave that we see running through it. And so the first thing we need to resolve is we can only stimulate for 5 seconds. How can we circumvent the issue of respiratory sinus arrhythmia? And that's why we decided to connect to the troughs indicated by T0, T1, T2, T3, so that we look at the line, which is like an average line running through the cycles. So then we calculate z-scores, and in this first study, we indeed interestingly demonstrated that the F3 and F4 locations were showing the most pronounced heart rate deceleration. We see no such effect, or actually the opposite, for the motor regions, C3, C4, and for the parietal cortex. And for the FC3, FC4, which you could consider to be roughly corresponding to the 5 centimeter rule, and we see a nice intermediate effect. And for some people, it was a slowing. For some people, it was not. It was no evidence of slowing. So of course, very important, because before we can consider using something like this in practice, the question is, well, does it replicate? And I think the simple answer is yes. I summarized here many ongoing and published replication studies. The most important one, I think, was an independent replication from Paul Fitzgerald's group, where they actually demonstrated for 10 Hz NCG TMS an identical pattern than what we originally reported. This is a first kind of review, as well as an individual participant meta-analysis. And here we see a summary of all the NCG TMS experiments conducted so far, which nicely replicates the main finding that we observed as well. And there was no difference no effect of laterality. And so meaning that there was no difference for this heart rate effect between the right and the left hemisphere. Then even more importantly, we also had one big experiment where we collaborated with Daniel Bloomberger, Fidel Rodriguez, and Jonathan Downer, who were kind enough to share with us some of their ITBs data they collected. But in those patients, they also collected EKG as well as blood pressure. And what that study mainly added is that it also applied to ITBs with even way more pronounced effects than we would have seen with the 10 Hz. But even more so, we also found that blood pressure as well as heart rate variability were responding in the same way. And so while being stimulated with ITBs, blood pressure dropped with a significant amount, and also heart rate variability significantly increased as well. And so this further proves that we are indeed transsynaptically activating the whole parasympathetic branch, which indeed is involved with regulation of all these psychophysiological parameters. Then in these studies, we also set out to extend the method much further. And here we actually aimed to use the 10 Hz NCG TMS. And we stimulated many different cortical areas, because we were thinking like maybe we can find a much more fine-grained way of identifying the entry into the network. And what the interesting thing is we found here is that both in healthy controls as well as in a group of patients, that it was only on the group level, the FC4 and the F4 locations that were showing heart rate deceleration, and all these surrounding sites were showing the opposite kind of pattern of an acceleration. And it nicely replicates across patients. And so there's no reason to expect a qualitatively different connectivity in patients, although on a functional level it might be, but the entry into the network is expected to be the same. Then knowing that's what Trevor already introduced at the beginning, that we can now actually speak of two different clusters, where we have the 5 centimeter cluster on one hand and the beam F3 cluster on one hand. And where we know that when you randomize people, it's never been done, but let's assume that we can randomize people to these two treatment targets, I would not expect any significant difference between the group. It would simply be two active treatment groups. And due to the differences in heterogeneity, you would expect on the average level quite similar outcomes. So then the question emerges, knowing that here on the group level as well, we see that FC4 corresponding to the 5 centimeter and F4 corresponding to the beam F3, F4 location, or coming out in the group level as well. Could we apply this technology on the individual level? And if someone shows a better deceleration at FC4, we will assign them to the 5 centimeter rule TMS. Whereas if the best heart rate deceleration takes place at F4, we would then assign them to the beam F3 TMS. And this is something that we proposed in this recent letter in brain stimulation, where we think that this method could already be used to some degree to stratify patients between these two different well-known clusters that are known to be effective already. And so this is also something that we will be testing in a prospective trial across 3 different clinics, where we will be investigating what the impact will be if patients will be prospectively stratified. Then here we see a recent study from Cash et al., where they applied actually the MRI methodology of the anti-correlation between the subgenual and prefrontal areas. And I think here, at least it's suggestive of 2 different clusters as well, and that you might identify in this method, I think quite similar to what we are finding as well, although the resolution might be a bit more significant, a bit higher here. But I think a real interesting idea going forward to use this methodology for treatment stratification and hopefully taking the guesswork out of selecting your treatment sites with TMS.
Wow, that's a great background into Neuro-Cardiac-Guided TMS. And so that was NCG 1.0. And now we're going to find out how far you've actually taken this. I think you've got some new information to show us today, Martijn.
Yeah, actually, this is data. This is all very, very recent. We've been starting to improve the method to some degree. And on that journey, we've come across a couple of quite surprising new insights where I think it might be nice if you would allow me to give the viewers a little bit more insight on that.
Yeah, please do. So NCG 2.0, hit us.
Okay, so remember that what we first conceived of was that when we stimulate the dorsolateral prefrontal cortex, we get an immediate transsynaptic activation of the subgenuine anterior cingulate. And we don't know exactly which pathways, we know a couple of them, but eventually it will result and it will trigger the further transsynaptic activation of the parasympathetic nerve. So that also means the parasympathetic nerve is myelinated. The accelerated nerve, for example, is unmyelinated. And this is a small detail, but it's important to appreciate because myelinated fibers have a much quicker conduction time, which means that the effects on the parasympathetic system are expected to be immediate. So I want to do a small thought experiment because this is what we did over the last couple of days ourselves. And then let's see if my thought experiment is something that works out. So let's now assume that this is the stimulation pattern that we are applying on the DLPFC, on the prefrontal area. So we're stimulating with 5 seconds on and then 11 seconds off. And people in the US might understand this protocol to be the DASH protocol. So also keep in mind that we've now switched from a traditional 10 Hertz TMS with a 25-second intertrain interval to just an 11-second intertrain interval. I'll explain a little bit later why we decided to move to this, because we think we might find better effects. So let's now assume that here we see the heart rate from someone. That means that if while the stimulation train is ongoing, that you would expect the heart rate to go down. And when the stimulation is finished, you have your wait time in between of 11 seconds. The heart rate has the ability to recoup and it goes back up again, right? Because it was pushed down and what goes down must come up, to say it in the inverted way. So then we see the heart rate going up again. And then upon the next stimulation train, you would then expect the heart rate to go down again. So here we see what happens on the cortical level, which is stimulation train. And here we see what happens on the heart rate level, on the heart level. So we could now do a very simple thought experiment and say, okay, well, from a very physical and mathematical point of view, that means we are looking at a cycle time of 16 seconds, 5 seconds on and 11 seconds off. If you would calculate that back, that means if you have one cycle that takes 16 seconds, then you do 1 divided by 16, that will result in 0.0625 hertz of an activity that you induce over the heart rate, or a rhythm that occurs about 4 times per minute, because 16 multiplied by 4 would be 64. So in that sense, it's roughly 4 times per minute. So this is the data. And I can show you many data, but here's the data of here you see the heart rate between 60 and 80 while we stimulate. And indeed, when the first train arrives, we see the heart rate is pushed back. When there's a release, then upon the second arrival, we see that the heart rate is pushed back again. So actually within this 1 minute of stimulation, we can count 1, 2, 3, 4 peaks. And here we see the difference because here we see the numbers of 5, etc. indicate the intensity that we stimulate with. Number 5 equals the motor threshold. And this is supra-threshold stimulation. And here we would see the normal respiratory sinus arrhythmia. So 1, 2, 3, 4, 5, 6, 7. And so here we see the number of cycles that are occurring are a little bit faster, if you will. So these are really tight to the respiratory cycle. Whereas once we start stimulating at high enough intensities, then we induce a rhythm based on the rhythmicity that emanates from the TMS. And here we see 1, 2, 3, 4, 1, 2, 3, 4. So we are inducing this rhythm. And actually, when you look at a very sophisticated frequency analysis, we can actually tell the individual stimulation bouts as well. So there's 1 minute, and this is the first train, second train, third train, fourth train. And this is not EEG, we're here looking at the EKG. So we're looking at the heart rate activity, and guess where the center frequency ends up? Exactly where we predicted it to be, 0.0625 Hertz. And this is not like a typical frequency you would expect from the heart rate variability to occur. And so the prediction we made here is something that we see happening actually on the cardiac level as well. So I hear you think, well, this can't be true. This is, well, let's see. I mean, this is ITBS. ITBS, interestingly, has a completely different cycle time. So as many of you know, you stimulate an ITBS pattern for 2 seconds on and 8 seconds off. So that means a cycle time of 10 seconds. So that would mean that the rhythm that we saw previously of 0.0625 Hertz should now be 0.1 Hertz. And this also implicates that we should see 6 cycles per minute. Everyone with me? I still hope so. It's a little bit mathematics, but I think it's really important because this really brings the causality into what we are doing. And this is no longer a correlational thing where we're looking for some heart rate changes, but we're really, if you will, for those who have an IT background, this is almost like a network connection. And this is the TCP/IP communication protocol between the heart and the brain. So this is what we have actually seen in some of the data that we already published, but we didn't pick up on it when we published it, because this is the data. You can see 120 seconds. So this is 1 minute of ITBS data. And we thought that we were looking at heart rate variability, but let's start counting it. 1, 2, 3, 4, 5, 6. And the sham data from the same subject look like this. And so here we see the same cycling, the respiratory sinus arrhythmia, but this is much quicker. And so we see 1, 2, 3, 4, well, probably something like 10, 15. And so the non-stimulated heart rate is completely differently modulated relative to the ITBS modulated. And so, and we've also run the analysis, and we see exactly a 0.1 Hertz frequency activity that is instigated upon the heart rate. Here we see it blowing up a little bit. This is one example. You can find it in the Isager et al. Paper that we published together with the Canadian group as well. And at that point in time, we were focusing on the average deceleration, but actually the real signal, you can see it sham, ITBS, ITBS sham. This is not simply heart rate variability. This is all, and let's count from 60 to 120 is 1, 2, 3, 4, 5, 6. And so we can really very robustly explain the frequency that we are introducing by the TMS frequency that we've been applying at the cortical level. So we thought that's a really exciting kind of development. And the reason why we decided to also focus on this DASH protocol is that we think that with the old-fashioned 10 Hertz protocol, we have a 25-second intertrain interval. And you can appreciate that the endogenous respiratory sinus arrhythmia might pop up back again when you allow the stimulation too long a time of stimulation off. And that's also what we appreciated with the ITBS, which already is this type of a pattern change, that the heart rate changes with ITBS were about 8 BPM on average, whereas there was only 2 BPM with the old 10 Hertz protocol. And that's why we were lucky and happy to see that the FDA has approved this DASH protocol. There's recent really good registry data coming out of the US as well that's shown that the efficacy and effectiveness of this protocol was quite comparable. There's no reason to not try it. And again, of course, in here, we wanted to focus on real stratification between the beam site and the 5 centimeter clusters. A very other important question that we need to focus on as well is we now are all using motor threshold based stimulation. So we establish the intensity of stimulation based on the thumb movement, and we extrapolate that to the prefrontal cortex. But I think we all know that's very unlikely to be realistic. And actually in the studies we published so far, we did find that the amount of heart rate deceleration was uncorrelated to percentage motor threshold. However, it was correlated to machine output. And so that's a very important indication that we also need to see if we can now start using and developing this method to really find dose response effects and establish prefrontal thresholding as well. I will not go in a lot of detail, but I can assure you we have collected a lot of data. We're currently writing it up and intending, my colleague Eva is intending to present it at Brain Stimulation, and we'll also hopefully be submitting it soon. But this is the current methodology that we developed. So we do 8 minutes of stimulation, 1 minute of rest, then 7 different intensities where only this one, number 5, corresponds to the motor threshold, but then we go down in steps of 5% of machine output. So this is not related to the motor threshold. So the -5, -10, -15, -20. And then you will see not many effects in the beginning, but once the intensity goes up, you see that the rhythm slowly starts synchronizing into the, especially here, 1, 2, 3, 4, in the 4 per minute kind of rhythm. Here we can also tell with a fine-grained way all the stimulation pulses, and here we can really see the activation, which is really centered around the frequency that we predicted it to be centered around. And here we can then really inspect the dose response effect, and this is only one location, this is the beam F3, but we then apply this to 4 different locations. We can test the significance of the dose response effect, which is only significant on an individual level for this individual at beam F3, and then we also can inspect the R and the slope, which are further informative on deciding what we're going to do. So for this patient, which is actually myself, I would recommend that I walk in. My beam F3 right location shows the best connectivity. So in my case, I would recommend 1 Hertz on the right DLPFC, defined as the beam F4 method. So this is, I think, really how we can use this from a stratification perspective. If you still want to stick to the left hemisphere stimulation, then you would simply inspect which one has the biggest R, and you would go for the 5 centimeter rule on the left in this case. Why this is so important as well is that this was one subject that we actually were trying this method on, and this subject actually experienced a syncope. And we know that a syncope is really something that is more frequently observed during TMS sessions as well. And very often people will attribute it to tension or like a non-specific side effect. But in this case, we were, I think, lucky enough to really have someone connected to an EKG as well. And we found that when we were stimulating, the motor threshold was at 60% of the machine output. So here we see stimulation at the motor output. Then here we see the RR intervals. The heart rate was at an average of 80, but pay attention to this towards the end of the session, it was going below 60. So I think it was a little bit of overstimulation taking place. We can already see that the rhythm is already instigated at the 45%. So while the motor threshold was at 60, we see the first signs of target engagement appear already 15 absolute points below the motor threshold. And we can really tell also that the heart rate variability was going up. So this was not a sign of anxiety or tension, because then heart rate variability would have gone down. And we can really tell that in this patient where the syncope occurred here, that actually the prefrontal threshold was much lower than the motor threshold. And so this is a very simple example of overdosing. And this is why I also think that this type of a technology can also be further developed to at least know a priori if someone's frontal threshold might be deviating too much from the motor threshold. So at least we can start at a lower stimulation intensity to really prevent a syncope from occurring. And so I think here we can also redefine the syncope like a specific TMS-induced side effect rather than a non-specific TMS-induced side effect, which I think is really important knowledge. So the syncope is actually the overdriven example of frontal vagal overdrive, if you will. With that, I also want to point your attention to something that we've developed in this prospective trial that we are going to conduct. We thought, well, how can we simplify this further and make this further accessible and pay attention to the fact that what we have now talked about in the second part is really NCG TMS 2.0. I think a real completely different approach to what we've seen before, but much more robust as well. So we decided to develop an iPhone app. It was still on my to-do list to once develop an iPhone app. So together with our colleagues and with a very good programmer, we actually developed this app. The interesting thing, what we wanted to do as well, is also bridge the gap between the clinician and the patient. Because we already know that heart rate variability biofeedback can be a very effective treatment for depression as well. So what we are really envisioning is that the patient will see this during the assessment. We see 1, 2, 3, 4, which are the different stimulation rounds with TMS. It will record the EKG activity from a polar chest strap, which is really affordable as well. And in this way, we can really measure the EKG. It will be stored, and via cloud-based processing, it will feed back to you the screen that I just shown you and which side was showing significant dose response effects. However, the patient will then have seen like, well, I'm coming to the clinic, my clinician is using this kind of an app. So this looks like something that's been really valuable for me because I remitted with my depression. So the patient can download the same app, not for this functionality, but they can use the play function, which actually provides them with individualized heart rate variability biofeedback, where they can train the optimized respiratory rate that they can respond best to as well. And we hope at least that this could be a kind of aftercare program as well, and where patients can really use this biofeedback to prevent a relapse from occurring as well. And we hope by combining the two, we can amplify that effect as well. We will develop this app, the Heart Brain Connect app, for the use in our trial, and Neurocare group will be further also releasing the app, probably in a kind of subscription model for clinicians going forward as well. So you can expect it pretty soon as well. So with that, I think, I hope I have convinced you of the fact that I think NCG TMS 2.0 can help you take the guesswork out of your TMS site selection. We plan to do a first live demo of the technology at Brain Stimulation in Charleston. The app will be available from the App Store into 2022. And we're also working on a high-end NCG Engage 2.0. And as you can imagine, there's much more work we'll still be doing. Also, the phase locking of the signal that we just observed is something that we can even optimize further to get a much more sensitive metric as well. And so I think there's a lot of exciting stuff happening. And finally, I think this, I don't want to underestimate, is that these are really the group of people that we work with, many collaborators, both from brain clinics, but also outside brain clinics, the colleagues at Neurocare group, where often we knock on that door, can we try something out on your machine? And that's how the NCG TMS is further developed as well. Many collaborators, and of course, Trevor, you for hosting me and being able to listen in to this one.
Well, Martijn, that's amazing. Thank you very much for that explanation of NCG 2.0, and we're really looking forward to trialing it out in 2022 with Neurocare, and I'm sure it'll be available for a lot of other people around the world with different technology as well, different devices. It is accessible to all sorts of devices, so really bridging the gap, as you said, between the research and the clinician very quickly. So look, it's been a pleasure to have you today, and thank you for allowing me to bring this to everybody, and for being on the interview today.
Well, thanks very much.